All right. So you guys should see MOUD treatment in the hospital setting. I think I'm sharing correctly. So I'm Ruben Strayer. I'm an emergency physician as well as an addiction physician living and working in Brooklyn. It's a pleasure to be back with you to discuss treatment of opioid use disorder with a focus on hospital management. I'm going to cover a lot of ground over the next 45 or so minutes. Feel free to interrupt with questions either in the Q&A or in the chat. I'm going to be keeping an eye on both, and we really have plenty of time. So there's no problem to stop and address questions as they come up. If you ask a question about a topic that I'm going to cover in the coming minutes, I may defer the question until after my slides on that point. We are going to have a quick break after my presentation, and then we're going to return for a discussion with a couple of panelists where we will have, again, lots of time to dive into topics related to my presentation, topics related to their areas of expertise, or any other relevant topic that you're interested in, or any irrelevant topic. I'm pretty easygoing, so we can chat about anything. Let's dive in. I'm gonna start with the most important take homes first. I'm gonna expand on all of this over the next few minutes. The most important thing we can do to stem the tide of opioid addiction, opioid overdose, is to keep opioid naive patients opioid naive by prescribing opioids judiciously. It turns out that it's the number of pills in your prescription that correlates directly with the likelihood for developing long-term use and the devastating harms associated with long-term use. In patients who are already affected by opioid use disorder, who already are suffering from opioid addiction, we want to identify those patients. Many of them present manifestly with overdose or withdrawal, but there are more occult cases that can be found by looking for people who are taking high doses of prescription opioids or other psychotropic medications, especially combinations of opioids and benzodiazepines. So we want to identify those patients. When we do identify OUD, engage the patient. Move them to treatment if they're not already engaged in medication-based treatment. The first choice for treatment of opioid use disorder is buprenorphine. We're going to talk about this at some length. Second choice is methadone. There are a couple of other choices as well, all of them distant third, fourth, and fifth choices. And then there are patients who are not interested in treatment right now. And for those patients, we move to harm reduction mode. One of our panelists is expert in that domain. So I may defer some specific questions on harm reduction to our discussion, to our panel discussion in the next hour. But I will certainly touch on a number of harm reduction strategies. And then finally, abstinence-based therapies don't work and should not be entertained. The only patients who should be in abstinence-based treatment paradigms are those patients who decline any other type of treatment. I don't think I need to say much at this point about the scope of the problem. Drug overdose is the leading cause of overall death of Americans under age 50. Number one cause of death overall among Americans under age 50, exceeding peak mortality from guns, HIV, and motor vehicle collisions. There have been 3 waves of the opioid addiction and overdose epidemic. The first wave was prescription opioids, basically iatrogenic from overprescribing, mostly from well-meaning docs, but also from pill mills, which is prescribing for profit. It took us a while, but ultimately we turned the corner on prescribing, which is great, except that there were already millions of Americans addicted to, dependent on opioids, and many of them got cut off by their prescribers, or their prescriber went to jail. And when their prescription supply dried up and they couldn't tolerate withdrawal, which many people can't, they turned to heroin. And the second wave of deaths was from heroin. Around this time was when the addiction medicine community got serious about opioid use disorder, and most of us learned how to pronounce buprenorphine. And we have devoted enormous resources nationally into turning the tide on opioid deaths, and we were making progress until the heroin supply was replaced by fentanyl. The treatment paradigms are the same, but fentanyl turns out to be much more dangerous and destructive than heroin for a variety of reasons. And the pharmacology of street opioids is just going to get more dangerous and more destructive as the fentanyls get more and more potent. And we see more and more contaminants like xylazine. So even though we are getting better and better at treating OUD, OUD is getting worse and worse. Fortunately, we have very effective treatments for this problem. Our challenge and our task is to get people treated. This is what happens when you empower an army of doctors to prescribe buprenorphine, Suboxone, for OUD, which is what France did with all of its general practitioners in 1996. Overdose deaths fell by over 80%. And it doesn't only work for French people. Baltimore saw an impressive decrease in overdose mortality despite a substantial increase in heroin potency in that same period by expanding access to medications for opioid use disorder. Not as big of an impact as in France because we don't have an organized healthcare system in this country, and certainly not in Baltimore. But MOUD, medications for opioid use disorder, absolutely works. This Swedish investigator randomized people addicted to heroin to buprenorphine or a 6-day buprenorphine taper, followed by placebo. All patients got regular addiction counseling. Treatment retention was 75% in the bup plus counseling group, and in the placebo plus counseling group, 0%. At 1 year, a fifth of the patients randomized to placebo were dead. And in the buprenorphine group, 100% survival. It's a small sample, but in this group, for every 5 patients treated with buprenorphine for 1 year, you save 1 life. Try comparing that to treatments for any other disease. Like, we are all on board with a treatment that has an NNT of 20 to increase exercise tolerance in CHF. Here we're talking about an NNT of 5 to save a life of an otherwise healthy 30-year-old who can go on and live another 60 healthy and productive years. I challenge you to find a treatment nearly as effective. So very deadly disease, very effective treatments. This is a study of 17,000 Massachusetts patients who presented to the emergency department with non-fatal opioid overdose. This is as high risk a cohort of patients as you can get. These are folks who are telling us, I'm going to die unless things change. And this graph displays the use of MOUD, MAT, over the following 12 months, and it's between 6 and 17%. We're doing better now. The study is from 2018, but we're not doing a lot better. We're perhaps up to about 25%. Most patients with this highly lethal, highly treatable disease are not getting the right treatment. Why is that? Why are more than 100,000 Americans going to die this year from a disease that is easy and inexpensive to treat effectively? The short answer is stigma. I'm not going to belabor the point, but we all know that Americans see addiction very differently than diabetes, heart disease, trauma, cancer, diseases that in many patients are the result of what could be considered bad choices. But we see addiction differently. We see addiction as a character flaw, as a failure of willpower. And so it is because of stigma that as a younger emergency doc, I sent so many patients from the emergency room back to the street in withdrawal, some of whom, no doubt, shortly thereafter ended up dead with a needle in their arm. And stigma is why, until recently, every doctor could prescribe OxyContin, a massively dangerous, massively abuse-prone opioid, but very few could prescribe buprenorphine, a very safe opioid that effectively treats addiction. The treatment of addiction has been, until recently, confined to a small subspecialty of psychiatry. It has been and remains comparatively difficult to get these patients the treatment they need, and almost none of us were trained to do it. I certainly wasn't. But we have to do it. And the history of medicine tells us that we will do it, because right now it's what our patients need. And now it's a lot easier to get patients with opioid use disorder the treatment they need, because the best treatment for OUD, buprenorphine, has after years of advocacy, finally been deregulated. Until January of last year, only clinicians with a special addendum to their DEA registration called a Data 2000 or X waiver could prescribe buprenorphine. But the X waiver is gone, and now any DEA registered provider can prescribe buprenorphine in the same way that you prescribe any other controlled substance. This is a huge step forward, and I hope to convince all of you that you should have a low threshold to administer and prescribe buprenorphine to your patients with opioid use disorder. But I'm going to take a step back for a moment and discuss the larger project of opioid stewardship and the management of different stages of opioid addiction. The first and actually most important step is to prevent opioid naive patients from developing long-term opioid use and addiction by being judicious prescribers. I'm going to come back to this in a minute. For patients with OUD who are not already in medication-based treatment, you should try to move all of them to treatment with buprenorphine. We do this all the time in the emergency department, and an inpatient stay is a critical opportunity to demonstrate to that patient that their withdrawal and their cravings can be managed with bupe. You can absolutely turn someone's life around with this therapy. For people with OUD who are revealed as such, as having OUD, but unwilling to be treated, these are patients who are not ready for recovery yet, but they will be if they live long enough. So for this group, move into harm reduction mode. The goal is to make their drug use safer so that they remain alive until they are ready to be treated. Harm reduction includes take-home naloxone, discussing safe injection practices, needle exchange programs, an open door policy. Tell them that when they are ready for recovery to go to the emergency department, we can help and we never close. Unrevealed patients who are being harmed by opioids come in many flavors. This is the group we generally call chronic pain patients, who are usually on high doses of daily prescribed opioids who complain of pain. And then there are the patients who conceal their daily opioid use. We used to see them very frequently in the emergency department, not as much anymore. This is an entirely separate lecture on chronic pain. It's in some ways a much tougher problem than the patients who are revealed as having OUD, and that's what we're going to focus on today. Again, apart from psychiatry, until the past couple of years, none of us were trained to do any of this, and we're absolutely still figuring it out as we go. Addiction medicine is a pretty exciting field right now with new techniques and new therapies, some of which I'm going to touch on. But you still save the most lives with the basics, and still today, most physicians do not understand buprenorphine or how to use it. So let's discuss that. The treatment of opioid addiction is what used to be called medication-assisted therapy, MAT. MAT is not the preferred term anymore, though it's a very entrenched term. But the term MAT says that the medication is an assistant, is a facilitator, is a stepping stone on the way to the real treatment, whatever that is. And that's not right. The medication is the treatment. So now MAT stands for Medications for Addiction Treatment. You'll also see the acronym OAT, Opioid Agonist Treatment, or OST, Opioid Substitution Treatment. But the preferred term is now MOUD, Medications for Opioid Use Disorder. It doesn't matter what you call it, as long as we all know what we're talking about, and we all understand that it is the treatment for opioid use disorder. There is no debate about this among experts because the science is beyond unequivocal. It is absolutely definitive. Abstinence does not work for most people with entrenched opioid addiction. Their brains have been hijacked by opioids, and it seems that in many cases this is irreversible or takes a very long time to reverse. Abstinence goes by many names, but what they all have in common is they do not include the use of opioid agonists to treat opioid addiction. 27% relapse on the day patients are discharged after inpatient opioid detoxification. 65% relapsed at 1 month and 90% within a year. And relapse today is not relapse in the good old days. Relapse today is very, very dangerous because street drugs have always been dangerous, but today they are even more dangerous. Many clinicians, and certainly most of the lay public, including lawmakers, and especially the patients themselves, are resistant to this notion. But it is crucial that healthcare providers, you and I, understand. The majority of patients who are opioid dependent will not succeed with abstinence. And that means that the appropriate response to a willing opioid misuser is not detox, even though that's what many of them come in requesting. And there are all sorts of systems in place to funnel patients into detox because, like the rest of American healthcare, the treatment of opioid addiction is contaminated by corruption and greed. And you all should know that the detox industry is viewed by experts as similar to shark oil, miracle cure, homeopath charlatans who prey on vulnerable, desperate cancer patients. And you all must know that the detox, counseling, 12-step inpatient rehab, abstinence-based therapies are not only ineffective, but very dangerous because after detox, these patients relapse, and the street opioid dose that worked for them a month ago is now going to kill them. Relapse today is shooting a drug you think is heroin, but it's probably something much more potent and dangerous. So the treatment of opioid addiction is not detox rehab 12-step. It's medications for opioid use disorder. That's not to say we shouldn't encourage therapy and support groups. People addicted to opioids benefit from talking to a therapist. Everyone in this conference would benefit from talking to a therapist. Lord knows I would. But opioid addiction is not a failure of willpower. It is a disease of deranged brain chemistry, and the treatment is an opioid agonist. The notion that abstinence is the right path for people addicted to opioids is related to another misunderstanding that we hear all the time, that methadone and buprenorphine are just replacing one addiction with another. This sentiment completely misunderstands what addiction is and completely misunderstands the difference between addiction and dependence. MOUD, medications for addiction treatment, is not substituting one addiction for another. It's replacing addiction with dependence. And the difference between addiction and dependence is everything. Addiction leads addicts to perpetrate massive harms on themselves and everyone around them, become criminals, and often die. People addicted to opioids who are successfully transitioned to agonist therapy return to normal, functional lives. They return to their jobs. They return to their families. They return to health in the most important sense of that word. Most people with entrenched opioid addiction who are transitioned to agonist therapy should probably be on it for the rest of their lives. And many of these folks lead essentially normal, functional lives indefinitely. So just to put one more point on this, it's so important and so widely misunderstood. The vast majority of people with opioid use disorder should not go to rehab or detox. They should be treated with the buprenorphine with or without psychosocial counseling. So what can you do as providers who haven't done an addiction fellowship? You can do a lot. You can change the way you think about opioid prescriptions. Judicious opioid prescribing is a big topic, but the most important point is that it turns out that it's the number of opioid pills in the prescription that matters. It turns out that the likelihood of long-term use arising from an opioid prescription, a prescription for acute pain like post-op pain, the likelihood of long-term use, which is often life-ruining or life-ending, correlates linearly with the number of days supply of the initial prescription. Chronic opioid use turns out to be an important post-op complication. Odds ratio of 5 after knee surgery in one study. 10% of opioid-naive patients in this series develop long-term use, which is a pretty stunning number, even for oncology. This study showed that in these patients who developed long-term opioid use after surgery, what happens is that surgeons prescribe opioids for the first 3 months, but by 9 months, the patients are getting opioids from primary care, pain medicine, and physiatry. And we in this country have been trained to vastly overprescribe opioids in all contexts. Here's a comparison of opioid prescribing between American and Dutch surgeons. 77% of American surgeons sent hip fracture patients home with opioids. In the Netherlands, 0 patients. Some of you are thinking, how can you not prescribe opioids to patients being discharged after a hip or ankle fracture? That's what I used to think too. That's effective marketing. Here you see a comparison of perioperative opioid prescribing in a large teaching hospital in Oregon and a large teaching hospital in Hong Kong. Same operations. These were head and neck surgeries, very different prescribing patterns. This group found that after lap chole, they were prescribing 50 Vicodins, but their median patient use was about 6 tabs, 6. So they put together a prescribing guideline, dropped their prescribing drastically without more refill requests. We know that prescribed opioids often go unused, unlocked, undisposed, which is a big problem, and that each refill is associated with a significant increase in opioid misuse. It's the number of pills that makes the most difference. The best number of opioid pills to prescribe is usually 0. The vast majority of patients we send home with opioids do not need them. Maximize non-opioid analgesics and prescribe opioids judiciously so that the patients that you are trying to help are not set down the path to misuse by your prescription. Many of us were taught that doesn't happen, but now we know it happens and is a frequent cause of opioid addiction. You see so many inpatients and clinic patients with opioid use disorder. When a patient is admitted for whatever and then develops opioid withdrawal on hospital day number 2, that is a hugely important event and an opportunity to change that patient's health trajectory in a way that is almost always going to be more impactful than whatever they were admitted for. When your patient unexpectedly develops opioid withdrawal on hospital day number 2, that patient is suddenly revealed as an opioid misuser, if they weren't already revealed. And it's also much more likely to be willing to move to treatment. And the occurrence of opioid withdrawal is the best time to initiate buprenorphine. So instead of treating that withdrawing patient with a dose of morphine or hydromorphone, which perpetuates the problem, treat the problem. Move that patient to recovery right there and then by initiating buprenorphine right there and then. And if that's not an option, consider the harm reduction techniques that we just mentioned, and we'll mention further in a few minutes. Lastly, I hope I've convinced you that detoxing opioid-dependent patients while they're on your service and sending them back to the street is very dangerous. Physical withdrawal symptoms will abate after some number of days, but the cravings do not abate. And when your patient uses street drugs after a period of detox, they are much more likely to overdose because their tolerance is diminished. As I mentioned, all of you can order buprenorphine in hospital or prescribe for outpatient therapy as of January 2023. There are a few things you need to know about treating OUD with buprenorphine. Bup is a pharmacologically complex and extremely cool drug. It has two major properties that make it remarkably well suited to treat opioid use disorder. The first is that buprenorphine is a partial agonist, which means that there is a ceiling effect to its toxicity. Buprenorphine is remarkably safe in overdose, not perfectly safe, but vastly safer than full agonists like heroin, oxy, methadone, morphine, etc. At the same time, buprenorphine has a higher affinity for the mu receptor than just about every other opioid, which means that a person who is therapeutic on bup is protected against overdose if they use heroin or fentanyl or anything else, because bup occupies the receptor and won't be displaced. That's buprenorphine blockade. Bup is very effective at treating opioid withdrawal syndrome, of course, vastly more effective than non-opioid alternatives like clonidine. But if an opioid-dependent person is not in withdrawal, meaning that they have enough full agonist of choice on their receptors, buprenorphine, having a higher affinity, will push the full agonist off their receptors. But because bup is a partial agonist, replacing a full agonist, the patient will suffer a loss of agonism and develop withdrawal. This is called buprenorphine-precipitated withdrawal. And so buprenorphine abolishes withdrawal, abolishes cravings, is very safe in overdose, and protects the patient from overdosing on other opioids. It seems like the perfect drug to treat opioid addiction. But it's not perfect. Buprenorphine itself can be abused by crushing and injecting. It can be sold on the black market. There's a lot of bup sold on the street. That's called diversion. It's illegal. Because bup has very little bioavailability when swallowed, it's administered sublingually. And in America, we have mostly used a combination product, buprenorphine naloxone, when bup is used to treat addiction, best known by its trade name, Suboxone. The theory, and the way that this is still usually taught, is that the bup is absorbed sublingually, but the naloxone is not. So if you take bup nalox combination product sublingually, as intended, the naloxone has no effect. But if you abuse Suboxone by crushing and injecting it, the naloxone, now injected, will precipitate withdrawal. So the only purpose of the naloxone component of bup nalox is to prevent abuse by injection. I want to linger on this point for a second because it's widely misunderstood. Precipitated withdrawal from buprenorphine naloxone, the combination product, trade name Suboxone, does not come from the naloxone. It's caused by the bup itself. The naloxone is only intended to be active when the preparation is abused by crushing and injection. But it turns out we were misled on the combination product. This is a little heavy into bupe pharmacology, but you guys can handle it. Sublingual buprenorphine is available as two products: the combination product buprenolox, trade name Suboxone, and the monoproduct buprenorphine alone. The trade name is Subutex. Turns out that the combination product, buprenolox, does a relatively poor job of preventing abuse. It does have some abuse deterrent effect, but we know it's a modest effect, that buprenolox can be and is abused by crushing and injecting, just like bupremono. And it also turns out that the naloxone component of buprenolox is absorbed sublingually, despite conventional teaching. Its bioavailability is low, but not zero. And for some people, a minority of patients who take buprenolox, the low levels of naloxone that are absorbed sublingually cause withdrawal symptoms that range from mild and just bothersome to quite significant. Where this gets a little weird is that buprenolox is universally recommended as the preferred buprenorphine preparation for addiction, except in pregnant patients, where, classically, the monoproduct has been recommended. But this recommendation that the monoproduct be used in pregnant patients is based on reasons that are also nonsense. So the bottom line is that you can use bupremono and buprenolox more or less interchangeably in anyone, pregnant or not. Just use whichever product you can most easily get your hands on, or which your patient can most easily get their hands on. Because the naloxone component of buprenolox causes trouble in some patients, in hospital, you should just use the monoproduct. And in fact, I've had the combination product removed from my hospital formulary. So inpatient, you can only use the monoproduct. For prescription, you should generally use the combination product because insurance companies have also been misled. And so they will often only cover the combination product, Suboxone. All right, so how do you do it? In most cases, it's straightforward. First, you need to identify patients who have opioid addiction and are not already in a buprenorphine or methadone program. We use the clinical opiate withdrawal scale, COWS, to quantify how bad someone's withdrawal is. If that patient is already in significant withdrawal, they've got a decent COWS score, or they tell you, Doc, I know how to use Suboxone. I'm sick enough. You can give it to me now. Perfect. Dose buprenorphine right then and there. The standard dose for someone who's using street opioids is 8 milligrams sublingual. If the patient is not in adequate withdrawal, they're at risk for buprenorphine precipitated withdrawal. So you can't dose them right now, and you need to figure out how to get bupe under their tongue soon. And this is the hardest part about buprenorphine, which is managing the patient who needs to be on bupe, but is not yet in adequate withdrawal to dose bupe without the risk of precipitated withdrawal. There are a few ways to manage this, which I'll discuss in a moment. The last step is follow-up, which is usually just sending the patient to a buprenorphine-capable clinic. That's it. There are endless complexities that can and do develop in managing these patients, but in theory, and most of the time in practice, it's straightforward. Here's an example algorithm for inpatient buprenorphine initiation that takes you through it step by step, from finding the right patient to initiation, to maintenance, to discharge. There are tons of similar care maps. This one is from California Bridge. Now, if you've identified a patient who would benefit from buprenorphine therapy, but is not in adequate spontaneous withdrawal, so you can't just give them the 8 milligrams now, there are a few options. The most common is home initiation. Easy, often successful. You need to write the prescription. The patient has to be able to get that prescription, and you need to give them some instructions on how to do it, like this handout, which is available at emupdates.com/help, and appropriate follow-up. This would only apply to inpatient medicine for patients you identify as having OUD shortly before discharge. The conventional way to manage inpatients who should be on bupe but still have their full agonist opioids in their system, meaning they're not in withdrawal, is to use non-opioids to treat the symptoms of withdrawal until the full agonist is gone. Many patients have tried this before. Ask them what works for them. It's quite reasonable to keep them sedated for a couple of days with a benzodiazepine and a butorphanol neuroleptic like haloperidol or droperidol until you're confident that they're ready for bupe, which for most people using street opioids, which is now mostly fentanyl, is 2 to 3 days after their last use. The other option, which is becoming more popular, is buprenorphine microdosing initiation. Since the term microdosing has been co-opted by tech bros who want to show up to the office high on mushrooms, we now call this technique low dose initiation or low dose overlap initiation. Whatever you call it, it's a very cool piece of pharmacologic jujitsu where you transition patients from whatever full agonist they're using, heroin, oxy, methadone, whatever, to buprenorphine without entailing a period of withdrawal. Consider a patient who just used his usual dose of heroin an hour ago, and he comes in and says, I've had enough, I'm ready for recovery, but all his receptors are occupied by heroin. He's not in withdrawal. He feels fine. And you say, great, here's 4 milligrams of sublingual buprenorphine. That's a conventional dose. What's going to happen is that all that buprenorphine is going to push most of the heroin off their receptors. And now you've replaced a brain full of heroin, which is a full agonist, with a brain full of buprenorphine, a partial agonist. That's a huge loss of agonism that will precipitate withdrawal, which nobody wants. Microdosing is when you take that patient with a brain full of heroin and you give him a tiny dose of buprenorphine, which will replace some of that heroin, but not enough to precipitate withdrawal. That's it for day number 1. You just give a tiny dose, like 250 micrograms of sublingual buprenorphine. Now, the patient is going to continue using a full agonist during the entire initiation, which lasts several days. The patient carries on with a full agonist while you microdose slowly escalating doses of buprenorphine. On day number 2, you give them a tiny bit more buprenorphine, which replaces heroin on a few more receptors, and you continue this on days 3, 4, 5, just giving a little bit more bupe every day while the patient is still using their full agonist. And because you are slowly, gradually replacing the full agonist with bupe, there's no withdrawal or minimal withdrawal. And eventually, you build up to a therapeutic dose of bupe, which is about 4 milligrams sublingual. And once you have 4 milligrams of bupe in your brain, you're protected from spontaneous withdrawal. So you can now discontinue the full agonist and titrate up the bupe to whatever dose you need to suppress cravings. There are pitfalls to bupe microdosing, low dose overlap initiation. The first is that it takes time. Even the most aggressive protocols take time, at least 3 days. And those are the highest, those protocols that are 3-day protocols entail the highest risk of withdrawal. Generally, it's better to do it over a longer period, like 5 days, 7 days. I've seen outpatient protocols that are 21 days. But during this longer initiation, you risk the patient getting fed up and quitting the process. This is a big problem when you try to do this as an outpatient, but it's much less of a problem inpatient. Microdosing initiations are a really good option for inpatient. You can get on top of the patient's withdrawal symptoms with, for example, methadone or morphine or hydromorphone or whatever you want, and slowly ramp up the bupe and keep the patient comfortable with other symptomatic meds as needed. And a few days later, the patient is therapeutic on bupe and can be transitioned to full dose bupe, which is a huge win. Let's say that you think the patient has enough withdrawal to give a full dose of bupe, like 8 milligrams, but the patient immediately gets much worse. You've caused precipitated withdrawal. We call this preciping the patient. Precipitated withdrawal is the most important thing to understand and the most important pitfall in bupe initiation. But we're learning more about how to manage buprenorphine precipitated withdrawal. There is almost nothing published on this yet. The pharmacology is not entirely understood. These patients are complicated. They often don't know what's in their system or may not want to tell us. The classic treatments are the same non-agonist treatments that have traditionally been used for spontaneous withdrawal. And just like spontaneous withdrawal, they don't work very well for precipitated withdrawal. But there is a substantial anecdotal experience and a little bit of literature on treating buprenorphine precipitated withdrawal with large doses of buprenorphine, 16 milligrams or more. And this seems, most of the time, not all the time, to work. And it's very hard to run into trouble with buprenorphine in opioid habituated patients. Bupe is very forgiving with a wide therapeutic window in people who use opioids every day. This is where I am with buprenorphine precipitated withdrawal at the moment. If I accidentally precip for a patient with 8 milligrams of sublingual bupe, I dose an additional 16 milligrams of buprenorphine. And most of the time that works, the patient feels much better. If it doesn't, stop and think, is there something else going on, like sedative withdrawal, DKA? It could be a million things. At this point, I'll start a line. If the patient doesn't already have a line, and do labs. I'll do a better history and physical. I'll think about imaging, but I will also dose another 16 milligrams sublingual. So now the patient has gotten something like 40 milligrams of sublingual bupe, which is a lot of bupe. And I've had a couple cases where that didn't work. And so at that point, I just snowed the patient with benzos, droperidol. There's some evidence that ketamine is very effective in these cases. These refractory precip patients, especially if they're older or have significant medical disease, can get pretty sick. And some of them will require resuscitation level care. Now, I say 40 milligrams is a lot of bupe, but there is literature supporting much higher doses. Again, it's very tough to cause harm with buprenorphine in opioid-dependent patients. This guy randomized patients to 32, 64, or 96 milligrams of buprenorphine. 96 milligrams of buprenorphine. That's the equivalent of about a gram of morphine. And everyone did fine. Ceiling effect. It's pretty cool. The reason that study was undertaken was to demonstrate that very large doses can prolong buprenorphine's duration of action to multiple days, which is, in fact, what happens. Here we see a craving score of 0 at 5 days in the 96 milligram group. I'm not sure exactly how you would give 96 milligrams. It would take 10 minutes just to like put all that in someone's mouth. Some of you might have noticed now that precipitated withdrawal is unlikely at microdoses, like 250 mics sublingual. And if the treatment of precipitated withdrawal is more bupe, which it looks like it is, that means that large doses of bupe, greater than 16 milligrams, are also unlikely to precipitate withdrawal, which also seems to be true. So buprenorphine precipitated withdrawal is a phenomenon that occurs mostly in this sour spot between 2 and 8 milligrams, which just happens to be exactly the conventional bupe initiation range that psychiatrists have been using for 20 years. So if a big dose, a macro dose, is less likely to precipitate withdrawal, which is the most important pitfall in bupe initiation, and a macrodose prolongs duration of action to 3, 4, 5 days, which it looks like it does, which is a huge safety benefit. Long duration of action is long duration of protection. Should we be using a macrodose to initiate more routinely? Maybe so. There may be some risks. The literature is evolving, but macrodosing initiation may be a good way. The best way forward is probably long-acting injectables. This study was published a few weeks ago. Could be very important. There are a couple of extended release buprenorphine preparations. The most important for the past few years is a preparation called Sublocade. This study looks at a brand new alternative called Brixadi, which is available in a weekly and monthly form. And in the weekly form, 24 milligrams, the blood levels of buprenorphine rise slowly, much slower than a dose of sublingual buprenorphine. And in this cohort of 100 patients with OUD who were in mild withdrawal with a COWS of 7 or lower, this group saw very little precipitated withdrawal, 14% in patients with a COWS of 0 to 3, so almost no withdrawal, and 3% precip in patients with COWS 4 to 7, which is still pretty mild withdrawal. So this is potentially what we've been waiting for, a single subcutaneous shot of bupe that will cover the patient for a week with a low risk of precipitated withdrawal, even in patients with low COWS scores. Let's hope that broader use shows us similar results. I should mention that I have no conflicts, by the way. I'm gonna save. I see no questions in the chat or the Q&A. I'm gonna save further question time for our panel discussion coming up. I want to say a few words on methadone. So methadone is absolutely a life-saving treatment of opioid use disorder, and there are hundreds of thousands of patients who have had their lives saved and their lives restored by daily methadone treatment. There are hundreds of thousands of Americans who are doing very, very well on methadone. But methadone is a distinctly second line agent for the treatment of OUD compared to buprenorphine. Methadone is as dangerous as any full agonist because it's a full agonist. So people absolutely can and do overdose and die with too much methadone. It gives you a much bigger bump than buprenorphine because it's a full agonist. It doesn't give you the bump of a rapid acting, short acting full agonist like oxycodone or hydromorphone, but absolutely gets you high much more so than buprenorphine. It doesn't provide protection from overdose with other full agonists like buprenorphine does. Patients on very high doses of methadone have some protection from overdose because their tolerance is so vast, but certainly methadone does nothing like buprenorphine blockade. And perhaps most importantly, as of 2024, methadone is only available in a daily visit to an opioid treatment program, an OTP, better known as a methadone clinic. Can you imagine having to go to a clinic every day to get your daily medication? It's insanity. Many people find this very inconvenient, and many people feel threatened waiting in line at methadone clinics, especially women. There are often drug dealers hanging out around methadone clinics, hoping to make some money off of people waiting for the methadone dose. So while the threshold to administer buprenorphine should be very, very low, the threshold to administer methadone should be a little bit higher. And in my mind, the main indication for methadone, again, a very important life-saving drug, is that the patient has failed buprenorphine or refuses to be treated with buprenorphine. In terms of methadone dosing, which is quite relevant to inpatient providers, if your patient is on methadone and they say that they've taken their dose within the past 48 hours, confirm that dose with the clinic, and then they can get their normal dose of methadone. So if someone took 90 milligrams of methadone yesterday and now they're admitted for pneumonia, you call the clinic, you verify that they got their 90 milligrams yesterday, and then you just give them their 90 milligrams daily. If it's been more than 48 hours, their tolerance is potentially already diminished, and so you can give them half their dose between 2 and 4 days since their last dose, if that's confirmed. Otherwise, if it's been more than 4 days, you have to start over with a conventional methadone titration, which can only be up titrated slowly. As an outpatient, methadone is up titrated over weeks, sometimes months. This is the classic methadone initiation pathway, where on day number 1, you give them 20 milligrams of oral methadone. Then you can give another 10 milligrams an hour or two later, and then a third dose of 10 milligrams for a maximum total dose of 40 milligrams on day number 1. And then on day number 2, if you're inpatient, you can divide that dose, the total amount that they got on day number 1, you can divide it BID, and then you can go up by 10 milligrams per day as needed to address cravings. This takes a long time to get patients where many of them think they need to be, which is what their methadone dose was at one point. Many patients are on 100 milligrams of methadone per day. There are many patients who are on 200 milligrams of methadone per day. And that takes a long time to get to that dose. You cannot quickly titrate methadone safely. In the era of fentanyl, there are slowly now, just in the past number of months, we're starting to see some rapid methadone titration schedules that have been published, but data is scant. Methadone is dangerous. If you can closely monitor your patients and have continuous pulse oximetry, it's reasonable to adopt a more rapid titration protocol to someone we know is a high-dose street opioid user. But if you don't, it's too early to start pushing methadone doses high quickly. Even though many of these patients can handle it, we don't know for sure which ones are going to handle it, which ones will stop breathing. So the best approach is today still to use a conventional initiation, which is outlined here, and then supplement with short-acting titratable opioids and then non-agonists to manage residual cravings and withdrawal as needed. So that's methadone dosing for inpatient clinicians. I want to say a word about pain management for patients who are on buprenorphine, who are bupe maintained, and they come in with acute severe pain or scheduled to have an operation. So I'm talking about the patient who, let's say, is on 24 milligrams of sublingual buprenorphine per day. They're on 8 milligrams 3 times daily, which is typical. And they have a scheduled sternotomy, or they broke their thigh and are now in acute severe pain. This is a pretty common problem, and it's going to become a more common problem because, fortunately, more and more people are on buprenorphine. The features of buprenorphine that make it so fabulous as a treatment for addiction also confound the dose of morphine that you want to use to treat their acute severe pain. The conventional strategy here is to discontinue the buprenorphine. So for a planned operation, for decades, the recommended strategy was to have the patient discontinue their buprenorphine for some days prior to the operation. Then they can be treated with usual full agonist opioids perioperatively. And then at the end of their period of acute severe pain or perioperative pain, restarted on their buprenorphine. This turns out to be a terrible idea for a variety of reasons. It entails that the patient go through withdrawal twice. First, when they discontinue their buprenorphine prior to the operation, and then, much more difficultly, later, at the end of their period of perioperative pain, they have to discontinue their full agonist, go into withdrawal, and probably have significant residual perioperative pain on top of that until they're ready to be dosed with buprenorphine again. Fortunately, we know now that you don't have to do this. And patients who are maintained on buprenorphine, who have an operation planned, or who are in acute severe pain from injury or illness, should be maintained on their buprenorphine throughout their period of acute severe pain or perioperative pain. You can use non-agonists to treat acute severe pain. Ketamine is fabulous in this regard. And then, of course, you can also use full agonists on top of the buprenorphine that they're taking. Now, they're going to require higher doses of full agonists, sometimes uncomfortably high doses, for two reasons. Firstly, because they have buprenorphine in their systems, and buprenorphine blocks the action of full agonists. So buprenorphine blockade protects them from overdose with heroin, but it also protects them from the fentanyl drip or the hydromorphone drip that your anesthesiologist wants to put them on. So you have to use higher doses. Secondly, these are opioid-tolerant patients. Buprenorphine is an opioid. And so they require higher doses for that reason as well. But you absolutely can and should use high doses of full agonists and partial agonists while they maintain their dose of buprenorphine. Some people like to drop the patient's dose of buprenorphine. So, for example, if they're on 24 milligrams, the theory is that you could liberate more mu receptors by dropping them to 8 milligrams during the period of acute severe pain or perioperative pain. And that's a fine strategy. It's generally not needed. The existing data suggests that you just use full agonists and high doses and non-agonists, and they do fine. And don't complicate the picture with reducing their buprenorphine dose. Just keep them on their buprenorphine dose, whatever it is, and add the non-agonists and full agonists on top of that. So that's the management of acute pain and perioperative pain in bupe-maintained patients. Okay, so we're at 11:55. We have a whole nother hour for panel discussion. So what I want to do as a little bit of a diversion, but an important diversion, is I just want to spend a few minutes, very briefly, talk about management of alcohol use disorder and tobacco use disorder, nicotine use disorder. Alcohol and nicotine are both devastating addictions that are prevalent and both kill more people in America every year than opioids. They don't kill people immediately in the same way that opioids do, and their use is sanctioned by decades of social conditioning, and especially in the case of alcohol, it's not just sanctioned but celebrated. we're just getting around to the idea that the ways in which we have attacked OUD as in the House of Medicine, we can now apply those same techniques and make a huge difference in the scores of patients who are affected by unhealthy alcohol use and nicotine addiction. So I want to spend a few moments on describing how you can do that. I just wanted to firstly call attention to this editorial in the New England Journal that proposes revising the labeling of alcoholic beverages similar to the warnings that have been applied to tobacco products. I didn't realize how important alcohol is as a risk factor for cancer, and I suspect that puts me in a group that includes just about everyone who drinks alcohol, which is just about everyone. So this is an important initiative. Alcohol withdrawal is something that we are all aggressive about treating in the emergency department and on inpatient wards. Most of us are very comfortable with it, and we all feel like it's part of our remit. It's part of our mandate to manage alcohol withdrawal, which is, of course, potentially very dangerous, immediately dangerous, which is why it's on our radar. But treating alcohol withdrawal without treating the underlying disorder is like treating diabetic ketoacidosis without treating the underlying diagnosis of diabetes. Alcohol withdrawal is a symptom of the disease of alcohol use disorder, in the same way that DKA is a complicating symptom of insulin-dependent diabetes, usually. So patients who have alcohol withdrawal have identified themselves as having alcohol use disorder and should be treated for alcohol use disorder. And it turns out we have effective treatments for alcohol use disorder. The treatments are not as effective as buprenorphine, which is something like a miracle drug for OUD, but they are effective. And the three treatments of greatest interest at the moment are naltrexone and gabapentin, along with acamprosate. This is a busy slide that summarizes the anti-craving medications for alcohol use disorder. Naltrexone is first line. 50 milligrams of oral naltrexone is modestly effective daily, is modestly effective in reducing alcohol cravings and reducing unhealthy alcohol use in patients who take it daily. Even better is the monthly depot naltrexone, trade name Vivitrol, which keeps naltrexone in your system for the duration of a month, which of course increases adherence, but also, and this is, I think we're now just coming around to a better understanding of this, having the naltrexone in your system, if you use alcohol, may be the most important way that naltrexone works. This is the theory behind the Sinclair method for naltrexone use in alcohol use disorder. I'm not going to say more about the Sinclair method here. I'm happy to discuss it in the next hour. But it basically operates on the principle that using alcohol stimulates our reward system, our endorphin-mediated reward system, and that endorphin-mediated reward system is abridged by having a mu receptor antagonist in your system like naltrexone. So taking naltrexone 50 milligrams in the morning, but then drinking in the evening may not produce the intended effect. Whereas taking naltrexone, for example, 1 hour before you drink, or having long-acting naltrexone in your system is likely to have a more powerful effect. Naltrexone has very few contraindications. The only real contraindication is concomitant opioid use. Obviously, you can't use naltrexone in a patient who is taking daily opioids. Liver failure is also a contraindication, but that's a relative contraindication and should be considered with a concern not just for liver failure, but the ongoing use of alcohol and its effects on the liver. So even in patients who have significant liver disease, they probably benefit from being treated with naltrexone. Acamprosate is the classic second-line alternative to naltrexone. That should, for patients who have a contraindication of naltrexone, acamprosate is the second line. Gabapentin is a newer therapy, has a significant anti-craving effect, also has an anti-withdrawal effect, so it's a nice single medication to use in patients who are at risk for both. If you're discharging, for example, a patient who has daily alcohol use and is expected to have some mild to moderate withdrawal. They don't need to be admitted, and they're interested in being treated for AUD as well, the cravings. You can manage it in that way. I'll just say a word about disulfiram, antabuse, of course, the most famous treatment for alcohol use disorder because of its excellently named trade name, antabuse. This is not really an anti-craving medication. It's more of an aversive therapy. It, of course, blocks aldehyde dehydrogenase, as most of you know, and creates a very unpleasant reaction, sometimes dangerous reaction, when even small amounts of alcohol are consumed. Antabuse has fallen out of favor in the addiction medicine community. It's no longer considered a top-line treatment for AUD. But if someone has been successful with antabuse, with disulfiram in the past, and they want a refill on it, by all means, treat them with disulfiram. There are, especially in supervised settings, which includes someone's wife, who might be the supervisor. Patients can be effectively treated with and maintained on disulfiram as a treatment for AUD. Let me say just a word about alcohol withdrawal management. We tend to overadmit these patients. Most patients who have alcohol withdrawal but are not in an ICU can be managed as an outpatient. Librium is extremely safe, very wide therapeutic window. I have all sorts of stories about patients who don't even have alcohol dependence, who got enormous doses of Librium, like 200 milligrams or more, and were fine. It really isn't abuse prone. It's the only benzodiazepine that's not abuse prone. So the threshold should be low to treat patients with chlorodiazepine epoxide. If someone goes out and takes a bunch of Librium and then drinks as well, they're likely not at increased risk for a bad outcome. Almost all these patients really can be managed as an outpatient with Librium. For inpatient management of alcohol withdrawal, in my hospital in particular, there's this, I can only speak for my hospital, but I know many of you have a long tradition of scheduled medications, Valium, PO or IV Valium, every 4 hours. This is poor care. And the reason that scheduled medications for alcohol withdrawal is poor care is because alcohol withdrawal is just a highly variant disease trajectory. And giving a scheduled medication to someone with alcohol withdrawal is going to overtreat or undertreat essentially all of them. Patients with alcohol withdrawal who are admitted to the hospital should be treated with a symptom-triggered treatment protocol based on a score. The classic score is SIWA, but SIWA takes a long time to administer, and there's a lot of subjectivity in administering the SIWA. Nurses don't like it. No one likes administering a SIWA, and so SIWA is part of the problem. I recommend using the brief alcohol withdrawal scale, BAWS, which takes about 1 minute to administer and promotes this symptom-triggered score-based assessment to determine when patients should be treated with their next dose of a benzodiazepine and what that dose should be. And this is an example protocol here, which you can see we can find at emupdates.com/BAWS, BAWS, brief alcohol withdrawal scale. I'm going to conclude with the final topic, treatment of nicotine use disorder. Nicotine kills more people than any other recreational substance. Unlike alcohol, almost nobody who is a long-term smoker wishes that they were continuing to use cigarettes. Most people who use alcohol are happy with their use of alcohol. The same cannot be said for nicotine, and it continues to surprise me that nicotine is as unregulated as it is, given the unbelievable harms that it perpetrates on patients who are chronic nicotine users. It's the leading cause of preventable death in the United States. Essentially, everyone who is a long-term nicotine user wants to stop, and most people cannot stop without medications. The treatments are effective, not as effective as buprenorphine, but more effective than the treatments for AUD. The treatments are, most people who get proper medication-based treatment for nicotine can stop or significantly reduce their nicotine use, which is an incredible benefit to them and everyone who loves them. There are 3 FDA-approved treatments, which is nicotine replacement therapy, varenicline, Chantix, and bupropion, Wellbutrin, Zyban. nicotine replacement therapy works. It works even by itself. It should be combined with another medication, ideally, but it works even by itself. When you administer NRT, it should be done in with a long-acting form and a short-acting form. The long-acting form is the patch, and the short-acting forms include gum, lozenges, inhalers, and nasal sprays. We always want to use both. If your patient will agree, you treat them with a continuous supply of nicotine transdermally, and then for cravings, you have them self-administer a short-acting hit of nicotine in the form usually of a gum or lozenge. The patches are available in 7, 14, and 21. There's essentially no role for the 7 milligram patch. People who are very light smokers can take 14. Almost everyone needs 21. If they're smoking more than 20 cigarettes a day, which is one pack, they should get two 21 milligram patches applied at the same time. And then there's the short-acting forms, which should be used in combination with the long-acting forms. Gums and lozenges are available in 2 and 4 milligrams. Almost everyone really should get 4 milligrams. And you just take them whenever you need them for cravings. They're often not taken properly. The gum is much more prevalent than the lozenge and should be administered in the chew and park method, which means that you put it in your mouth, you chew it until you feel a little tingling, and then you park it in your gum, like you do with dip, and you let it sort of tingle into your gums, and then the tingling runs out. So then you chew it a little bit more until it starts to tingle again, and put it back in your gum and park it there, and you continue that process until all the tingling of the gum runs out, just 30 to 60 minutes. All patients really should be treated with NRT unless they decline Chantix, varenicline. Very, very effective treatment for a nicotine use disorder. It's a partial agonist at the nicotine receptor, so it's kind of like buprenorphine for cigarettes. Very well tolerated. There used to be a black box on it, which has been revoked. It carries a lot of stigma because of psychiatric concerns. Most patients will have crazy dreams, so you need to warn them about that. A small number of patients will have an important change in mood, and that's really the only thing you need to say. You say you're going to have crazy dreams, and sometimes people who use Chantix have significant mood changes. If someone has significant mood changes while they're on Chantix, they just need to stop the Chantix. And that's what you need to tell patients who you start on varenicline. You ramp up slowly with a starter pack, and then you use a continuation pack. Each of these is 30 days. It's a 12-week program, can be repeated at least once, probably can be used indefinitely, although you don't see a lot of literature on that. It should be, by default, combined with nicotine replacement therapy, as I just mentioned. Very, very effective treatments. Bupropion is a second line, not as effective as Chantix, but is a little bit of a stimulant, which combats the weight gain that some people can see when they stop smoking. So important in that context. And then, of course, is an antidepressant. So for patients who have some mood issues as well, bupropion is a nice alternative. Cannot be used in patients who have a seizure disorder. Patients on bupropion should really be monitored by someone. So in my own practice, I will give out nicotine replacement and varenicline to essentially everyone, whether they have follow-up or not. Before I write a script for bupropion, I want to make sure that someone's watching them. Effective treatments. I want to just lastly call attention to a change in the way that we think about treating nicotine use disorder and talk to patients about nicotine use disorder. There's still this idea of quitting smoking, and there's still a lot of language and marketing around quitting. And because that's how we've marketed and talked to patients about smoking cessation for so long, many smokers have a lot of emotional trauma around a quit date and quitting smoking, because so many people who have nicotine use disorder have tried to quit and failed. And so they build up this idea of a quit date as like this mountain they have to climb over. So we don't want to talk about a quit date anymore. The way you talk about nicotine use disorder and tobacco use is as a disease, and you say you have the disease of cigarette addiction, you have nicotine use disorder. The treatment is nicotine replacement and varenicline. You have the disease, we have the treatment. just start taking the treatment. That's it. Don't even talk about it. You can reduce your use as you go, as you feel. When you feel an urge, try to take a piece of gum instead of quitting a cigarette. But if you need a cigarette, have a cigarette. And the idea is to sort of diffuse the idea of a quit date, which has so much emotional baggage to so many people. This is a study by Steve Bernstein. It's out of the emergency department, which basically shows that when you approach people who are smokers and you engage them with treatment, most people will accept treatment and it's effective. This is something we absolutely should be doing in the emergency department and 100% should be doing upstairs on inpatient wards. And the last topic is e-cigarettes, vaping as a form of nicotine replacement. This is very controversial, but I think that experts agree that vaping nicotine is much safer than smoking combustible cigarettes. And so if everyone who is already smoking combustible cigarettes transitions to vaping, it's probably a net win for that person. We don't know a lot of the long-term data. People who vape a lot more than they smoke cigarettes, and that's a problem. But combustible cigarettes are extremely dangerous, and vaping nicotine seems to be less so. Taking a child or a teenager who is not smoking cigarettes and exposing them to vapes is horrible. This is a huge loss for society. And so we've really messed this up in our country. They've done much better in Britain. We're finally course correcting with regard to Juuls. But someone who's addicted to cigarettes, who replaces that addiction with an addiction to vaping nicotine, is very likely doing themselves a big service for their health. And this is a couple of trials. Of course, a lot of these products the nicotine replacement is available for free. If you call the quit line, government and almost every state will send you patches and gums. I hope I've convinced you that those of us who are not specially trained in addiction are not only able to have a huge impact on the epidemic, we are the only way to turn the tide in the epidemic because addiction specialists are way too small in number, but more importantly, because we're the ones in the emergency department and upstairs on the wards who are already caring for these patients. So it's our charge to do so, to expand the scope of our practice. Thanks very much for your attention. I think what we'd like to do after that is take a brief break and come back, let's say at 12:20 with our panel.